Christian Doppler was an Austrian physicist. In 1842, he described the physical principle which now bears his name. The past decade has seen technological advances that have resulted in an application of the Doppler effect to the non-invasive study of blood flow within the heart and great vessels. Our common experiences of the Doppler effect involve moving sources of sound, such as a train whistle. As the train moves toward a listener, the wavelength is compressed. This results in an increase in frequency. As the train moves towards us, the pitch of the whistle increases. As the train moves away from us, the opposite occurs. The wavelength is expanded, and the frequency of the whistle decreases. The Doppler echocardiographic transducer is used to transmit a beam of ultrasound into the chest cavity. In this case, the beam is being directed toward a jet of blood resulting from aortic stenosis. The transmitted beam has a constant, known frequency. As the sound is reflected from the red blood cells within the jet, they become tiny moving sources of sound. In a manner analogous to the moving train whistle, movement of the red blood cells causes a shift in the frequency of the reflected sound beam. The change in sound frequency resulting from the red blood cell motion is known as the Doppler shift frequency. Doppler echocardiographic instruments are able to very precisely measure this Doppler shift frequency simply by subtracting the known value for the transmitted frequency, f sub 0, from the frequency of the beam reflected from the red blood cells, f sub r. The ability to precisely measure this Doppler shift frequency is extremely important because this shift is directly proportional to the velocity of the blood cells. This relationship is defined by the Doppler equation. Here, f sub d is the Doppler shift frequency measured by the instrument. F sub 0 is the transmitted frequency, which is a known constant for each transducer. V is the velocity of blood flow. C is another known constant, the speed of sound through blood. Theta is the angle between the axis of blood flow and our sound beam axis. In this example, the jet of blood comes through the aortic orifice in this direction, while the sound beam is directed along this axis, thereby creating this angle, which is theta. Rearranging the Doppler equation, we see that we can calculate V cosine theta from the known constants and from the Doppler shift frequency measured by the instrument. The Doppler shift frequency is here labeled as delta F. V cosine theta is the radial velocity. That is, it is the component of the velocity vector acting along our sound beam axis. For clinical work, we want to determine the maximum radial velocity. From the values of cosine listed here, you can see that the maximum velocity will be obtained when the angle theta is 0 degrees. Cosine theta will then be 1, and it will drop out of the equation. In our clinical work, then, we must strive for this situation, where we have aligned our Doppler beam exactly along the major axis of blood flow, and theta is 0 degrees. We will then be able to precisely calculate the velocity of blood flow. One immediate application is to use the blood velocity detected with a Doppler instrument to determine volumetric flow. The blood flow through a tube is obtained by multiplying the mean velocity of blood flow through the tube times the cross-sectional area of the tube. With a two-dimensional echocardiographic instrument, we can measure the cross-sectional area of the ascending aorta. We have just seen that the velocity of blood flow in the ascending aorta can be precisely measured using a Doppler instrument. Since the velocity changes throughout systole, the instrument will give us a velocity curve, and this can be integrated. Multiplying the velocity integral times the aortic cross-sectional area, we obtain the stroke volume. This, of course, can be converted to cardiac output simply by multiplying by heart rate. Instruments are now available that make this calculation of cardiac output once the examiner has simply measured the aortic diameter and the velocity of aortic flow. Several authors, including Dr. Rick Nishimura at our institution, have shown that this non-invasive Doppler method for measuring cardiac output is indeed accurate. In this graph, the cardiac output measured by Doppler in the medical intensive care unit is compared to that measured by the standard invasive thermodilution technique. You can see the excellent correlation. This graph again emphasizes the error introduced when our sound beam is not properly aligned with the blood flow. Theta is plotted along the x-axis, and the velocity obtained by Doppler is plotted on the y-axis. The numbers above each curve are the true velocities that we wish to measure. As you can see, when theta increases beyond about 20 degrees, an unacceptable underestimate of the velocity occurs. And this error will be reflected in other measurements, such as cardiac output. Fortunately, in most clinical situations, we are able to find an ultrasonic window that will allow us to orient our sound beam axis directly along the major blood flow axis. In addition to volumetric flow calculations, the velocity of blood flow obtained during Doppler examination can also be used to calculate pressure gradients. With stenotic lesions, the cross-sectional area for blood flow is reduced at the site of stenosis. We have already seen that blood flow, here labeled Q, is found by multiplying the mean velocity of the blood flow times the cross-sectional area. Blood flow will be maintained at a constant level across the stenosis. That is, the blood flow proximal to the stenosis must be equal to the blood flow distal to the stenosis. From the equation, it is apparent that the blood velocity must increase distal to the stenosis in order to maintain constant flow through the smaller cross-sectional area. The force necessary to generate this acceleration of blood across the stenosis is represented by the pressure gradient, the difference between the higher pressure on the proximal side of the stenosis and the lower pressure distal to the stenosis. The pressure gradient is mathematically related to the blood velocity via the Bernoulli equation, which is quite complex. Fortunately for clinical cardiovascular applications, this equation can be greatly simplified. The portions of the equation relating to viscous friction and flow acceleration are negligible and can be ignored. The portion of the equation related to convective acceleration remains. Here, rho is the density of blood, V2 is the velocity of blood distal to the stenosis, and V1 is the velocity of blood proximal to the stenosis, with velocity being expressed in meters per second. The density of blood must be converted to units such that the right-hand side of the equation yields millimeters of mercury. When this conversion is made, rho is 8, and therefore 1/2 rho is 4. The pressure gradient, P1 minus P2, is then equal to 4 times V2 squared minus V1 squared. In most clinical situations, the Bernoulli equation can be simplified even further. The velocity proximal to a stenosis is very low compared to the velocity distal to the stenosis. Therefore, V1 squared becomes negligible compared to V2 squared, and V1 squared can be dropped from the equation. This leaves us with the greatly simplified version of the Bernoulli equation that we use in everyday clinical work. The pressure gradient across a stenosis is equal to 4 times the square of the velocity distal to the stenosis. Consider this clinical example. This patient has aortic stenosis. Note the prolonged systolic ejection murmur on the phonocardiogram. The Doppler velocity spectrum from the ascending aorta is here. The peak velocity is 5.7 meters per second. In order to arrive at the aortic gradient, we square this value of 5.7 meters per second and multiply times 4. This yields a gradient of 130 millimeters of mercury. Dr. Mark Callahan from our institution verified the simplified Bernoulli equation using an open-chested dog model. A snare was placed around the ascending aorta, and a wide range of pressure gradients was produced. These gradients were measured by pressure tip transducers in the ascending aorta and left ventricle. Doppler signals were simultaneously obtained using a continuous wave Doppler transducer placed above the level of the obstruction. In this example, the aortic snare was progressively tightened, producing an increasing pressure gradient as measured by the catheters. Note that the Doppler velocity spectrum also increases, maintaining a precise relationship to the pressure gradient on a beat-to-beat basis. In this particular beat, for instance, the maximum catheter gradient is 92 millimeters of mercury. The corresponding Doppler velocity spectrum peaks at 4.7 meters per second, yielding a maximum pressure gradient of 88 millimeters of mercury as calculated from the simplified Bernoulli equation. Data from a total of 120 sinus beats was obtained. The maximum catheter gradient was compared to the maximum gradient obtained by Doppler and the simplified Bernoulli equation. You can see the excellent correlation with an R value of 0.99. Of course, in non-invasive clinical work, we cannot place our Doppler transducer directly on the ascending aorta, and therefore proper alignment with the stenotic jet is more difficult. This graph emphasizes the error that can be introduced into the gradient calculation if the Doppler beam is not properly aligned with the stenotic jet. The true gradients are indicated above each curve. The gradients calculated from Doppler measurements are along the y-axis, and various values for theta are along the x-axis. You can see that significant underestimation of the gradient results when the angle theta is greater than 20 degrees. When performing the Doppler examination, we arrive at a low value for theta by selecting a transducer location that is on line with the stenotic jet, and then making very fine manipulations of the transducer in all directions until the maximum velocity is obtained. For aortic stenosis, where the jet can be quite eccentric, we further ensure a minimum value for theta by performing the examination from multiple transducer locations. The Doppler examination can be guided by 2D imaging. The region of interest is imaged in the standard fashion. In this case, an apical 4-chamber view has been obtained. A Doppler cursor is then directed across the image along the expected axis of flow. This is referred to as duplex imaging. Here the cursor has been directed across the mitral valve. This particular instrument provides a movable cursor that the examiner can steer from side to side. Other Doppler instruments have a cursor that occupies a fixed position on the screen. The examiner must then manipulate the 2D image so as to bring the region of interest in line with the Doppler cursor. The Doppler exam can also be performed without 2D guidance, using a non-imaging transducer. The examiner is then guided by the Doppler spectral display on the screen and by the Doppler audio signals. The non-imaging transducer is quite small. Its tip is designed to fit nicely into the intercostal spaces and into the suprasternal notch. The examiner is therefore often able to achieve angulations of the Doppler beam that are not possible with the bulkier 2D transducer. The Doppler-derived velocity information is displayed on the screen and may also be recorded on a strip chart. This is a Doppler velocity spectrum obtained from a patient with very mild mitral stenosis and significant mitral insufficiency. As with the M mode, time is represented along the horizontal axis of the screen. The velocity, in meters per second, is recorded on the vertical axis. By convention, flow toward the transducer is recorded above the baseline, while flow away from the transducer is recorded below the baseline. In this case, the mitral valve was inspected by positioning the non-imaging transducer at the cardiac apex. Diastolic flow across the valve moves toward the apex, and therefore the diastolic mitral velocity signals are here recorded above the baseline. On the other hand, the jet of mitral regurgitation will move away from the apex, and therefore the systolic regurgitant velocity spectrum is recorded below the baseline. The calibration markers equal 0.5 meters per second. So the peak mitral diastolic velocity here is 2.4 meters per second. The jet of mitral regurgitation is much faster, measuring 5.5 meters per second. These blood velocities result in Doppler shift frequencies that fall within the audible range. This means that the Doppler velocity information can also be displayed as an audio signal. The greater the velocity of blood flow, the higher the Doppler shift frequency. We have already seen for this particular patient that the velocity of the mitral regurgitant jet is much higher than the velocity of diastolic mitral flow. Therefore, we would expect the pitch of the systolic audio signal to be much higher than the pitch of the diastolic signal. Pay attention to this feature as we again display the Doppler information in real time. There are currently available 4 different modes of Doppler interrogation: pulsed wave, high pulse repetition frequency, continuous wave, and color flow. Commercially available instruments vary in their capabilities with respect to these various modes. Pulsed wave Doppler is performed by utilizing a transducer that emits and receives bursts of ultrasound. These bursts are emitted at a regular rate, and that rate is the pulse repetition frequency of the transducer, commonly abbreviated as PRF. The major advantage of pulsed wave Doppler is that it can be time-gated. This allows us to focus attention on signals arising from a given depth, such as acoustic interface 4 in this diagram, filtering out all signals arising from other levels. In the pulsed wave mode, we analyze only those signals originating in a tiny three-dimensional space referred to as a sample volume. The sample volume is here represented as a small horizontal line. This is an apical four-chamber view. Right ventricle, left ventricle, left atrium, right atrium, tricuspid valve, and mitral valve. The Doppler cursor has been placed through the left ventricle and mitral valve and into the left atrium. The sample volume has been positioned in the left atrium, just behind the mitral leaflets. This is the corresponding Doppler spectral display. The ECG is below. Note this systolic signal. Since we are only analyzing flow within the sample volume, and since the sample volume is in the left atrium, this signal must represent mitral regurgitation. The sample volume has now been moved to a position approximately 2 centimeters deeper in the left atrium. In the Doppler spectrum that follows, you will see that the mitral regurgitant jet can also be detected at this level in the atrium. Pulsed wave Doppler, then, is useful for detecting flow disturbances at specific locations within the heart and great vessels. The maximum velocity detectable in the pulsed wave mode is limited by a phenomenon referred to as frequency aliasing. The largest Doppler shift frequency that can be detected is equal to 1/2 the pulsed repetition frequency of the transducer. This highest detectable frequency shift, which corresponds to a maximal detectable velocity, is called the Nyquist limit. This patient has mitral stenosis. We are using a duplex transducer. The Doppler sample volume has been placed on the left ventricular side of the mitral valve to analyze the diastolic jet. This is the resultant pulse Doppler velocity spectrum. The calibration markers are 0.5 meters per second. In diastole, the jet of mitral stenosis will be directed toward the transducer, which is at the apex. The diastolic velocity spectrum is therefore initially recorded above the baseline. However, the velocity of the jet has exceeded the transducer's Nyquist limit, and aliasing has occurred. The top portion of the velocity spectrum has been chopped off and wrapped around and appears below the baseline. We therefore cannot determine an accurate maximum velocity, and this prevents us from calculating an accurate pressure gradient. One solution to frequency aliasing is to increase the pulse repetition frequency of the transducer. Because of the previously mentioned relationship, this automatically increases the Nyquist limit. This is the same patient with mitral stenosis, but the instrument is being utilized in the high PRF mode. Note that there are now 3 sample volumes. Since we will be sampling at 3 different sites in the left heart, the study will be ambiguous with regards to the exact origin of the resultant Doppler signals. This is of no concern when analyzing stenotic jets, since we are only interested in the peak velocity occurring along the axis of the cursor. This is the spectrum obtained in the high PRF mode. The calibrations represent 1 meter per second. Since 2 sample volumes are in the left ventricle, left ventricular outflow tract velocity is recorded below the baseline in systole. The entire diastolic spectrum is now recorded above the baseline, and we can measure the peak velocity, 2.2 meters per second. This corresponds to a maximum early diastolic gradient of 19 millimeters of mercury. Another solution to aliasing is the continuous wave mode. Here the transducer emits and receives a continuous beam of ultrasound rather than a series of bursts. The continuous wave mode can be thought of as having an infinite pulse repetition frequency. Therefore, aliasing does not occur. The continuous wave mode is the one we most frequently use for studying stenotic jets, particularly the very high velocity jet of aortic stenosis. Returning to the same patient with mitral stenosis, the transducer is again at the apex, and a continuous wave cursor has been directed through the left ventricle and across the mitral valve. We are now sampling all along the cursor. Here is the corresponding Doppler spectrum. The entire diastolic jet has been recorded above the baseline. The calibration markers are at 1 meter per second, and the peak diastolic velocity for this beat is 2.5 meters per second, allowing us to calculate a maximum early pressure gradient of 25 millimeters of mercury. In real time, in addition to the diastolic audio signal from the mitral stenosis, you will also hear a faint systolic audio signal due to mitral regurgitation. Color flow Doppler is a very special and complex application of pulsed wave technology. The two-dimensional sector is divided by multiple lines or rays. Multiple pulses are transmitted in each of these beam directions, such that each line is divided into hundreds of sampling sites or sample volumes. This means that there are thousands of separate sampling sites within the entire sector. Velocity information is received from each of these sampling sites, and an autocorrelator analyzes it, converts it via a color code, and displays the color information in real time, simultaneously with the 2D images of the heart. The velocity information that is obtained from each of these small sample volumes includes the magnitude of the velocity, the mean direction of the velocity within the sample, and the spectral variance, which is a measure of the degree of turbulence. By convention, flow directed toward the transducer will be displayed in red, while flow directed away from the transducer will be in blue. The intensity of each color increases as the magnitude of the velocity increases. There are multiple shades of red and blue. Extremely low velocities are encoded in black and are therefore not visualized. Since color flow Doppler utilizes pulsed wave technology, aliasing will occur with higher velocities. This patient has mitral stenosis. This is the left ventricle and mitral valve. Note that the central portion of the mitral diastolic jet is blue. This does not mean that reversal of flow has occurred. The entire jet is moving toward the transducer. However, the jet has high velocity and color aliasing is occurring. As the Nyquist limit is exceeded, there is color wraparound or color reversal. The blue center is simply evidence of the high velocity. On some instruments, the amount of turbulence within the sampling sites is represented by the addition of green hues to the color display. The greater the degree of turbulence, the more intense the shade of green that is added to the color signal. Highly turbulent flow results in marked mixing of colors, yielding a mosaic appearance. In this example, the sector is focused on the left ventricle and enlarged left atrium. The aortic valve is partially seen and is closed. The thickened mitral leaflets are open. Jets of mitral stenosis and aortic insufficiency merge in the left ventricle. Since both jets are toward the transducer, the dominant color is red. Green is added because of turbulence, and the color mixing creates a mosaic. Now, in systole, the mitral valve is closed. Since the mitral regurgitant jet is directed away from the transducer, the dominant color is blue. The jet has very high velocity, and the red is due to color aliasing, while the green has been added because of turbulence, and again, the color mixing has created a mosaic. Contrast this with the pure blue color of laminar flow toward the left ventricular outflow tract. This small area of red is simply due to color aliasing.